I am happy to join medical students in this series of lectures in the cardiovascular disease. The topics of our lecture today is the valvular heart disease. We will have an aortic valve disease. Let us to start with aortic stenosis. Our objectives is to know etiology, pathophysiology, physical examination, natural history, and investigation of choice to confirm diagnosis and proper treatment. Aortic valve between the left ventricle and aorta is three cusps: right coronary, left coronary cusp, non-coronary cusp. And this is another picture for stenosis valve. Normal aortic valve areas, normally 3 to 4 square centimeter in adult. Symptoms occur when valve area is less than 1/4 or 1/3 of normal area. We have three types of supravalvular and subvalvular and valvular. The commonest is the valvular. Supravalvular and subvalvular rare. Supravalvular uncommon, associated with Williams syndrome. This syndrome consists of hypocalcemia, elephant faces, pulmonary stenosis, hypoplasia of aorta, stenosis in the other branch of other arteries like renal arteries, celiac, superior mesenteric arteries. This is the pictures of the William, the pressed nose, low set ears, and the elephant faces. Valvular, the most common, either congenital from bicuspid aortic valve or acquired due to the degenerative. Bicuspid aortic valve is the most common congenital cardiac anomaly, with about 0.5 to 2% of congenital heart disease. Please pay attention. If we say the most common congenital heart disease in all age groups is bicuspid aortic valve. The most common non-cyanotic congenital heart disease in children is the VSD. And the most common cyanotic heart disease is the tetralogy of Fallot. But all age group, most common is bicuspid aortic valve. Subvalvular is a rare associated with the hypoplastic left heart syndrome, idiopathic hypertrophic subaortic stenosis, or hypertrophic cardiomyopathy. So etiology of the aortic stenosis: congenital, rheumatic, and degenerative, mean calcific. In short, patient under 70 years old, more than 50% have a congenital cause, bicuspid aorta, while patient over 70 is a degenerative, more than 50 due to the degenerative, either three cusp or than the unicusp or the bicusp. So this table we saw the etiology, either congenital or acquired. Congenital aortic stenosis or congenital bicuspid valve can occur with the unicusp, bicusp, tricusp valve, commonly associated with aortic coarctation, aortic dissection, and the aortic aneurysm. Onset of symptoms in a third or fifth decade, while acquired is a disease of elderly, either degenerative calcification, rheumatic heart disease, or rare causes. Onset of symptoms in a seventh to eighth decade. Higher incidence of the risk factor for coronary artery disease like hyperlipidemia. Adhesion and effusion of commissures and cusps. Infectious vegetation, Paget disease associated with SLE, rheumatoid arthritis, post-radiation, incubation period in general between 11 to 16 years old after exposures. This is a pictures of the normal three cusp. This is right coronary, left coronary, right coronary, non-coronary cusp. This is bicuspid aortic valve. And this is senile degenerative, like that at the margins of the cusp, there is the calcium and degenerative change. While in the bicuspid aortic valve, it's congenital, this is a diffuse, there is a calcification. and this is that the degenerative at the margins of the valve, growth sample. Also, this is that the also a stenotic valve and the normal valve, tricasp valve. Pathophysiology of aortic stenosis is a pressure gradient, so it's a pressure problem developed between the left ventricle and the aorta. Increase, it means, in other words, increase after load. Left ventricular function initially maintained by compensatory pressure hypertrophy. When compensatory mechanism exhausted, left ventricular function declines. So it is normal area, as we said, 3 or 2 to 4 square centimeter. Severe stenosis less than 1 centimeter. Critical aortic stenosis less than 0.7, 0.5. Hemodynamic hallmark is the systolic pressure gradient between left ventricular and aorta, and 50 to 100 millimeter gradient are common in severe aortic stenosis. This is more than 100 millimeter of mercury gradient between left ventricle and aorta. And there is a relation between the surface area, severity, and gradient. So if the surface square centimeter and gradient millimeter of mercury. If the 3 on 1/2, it's about 10 to 15 gradient millimeter of mercury. While if the less than 1, it increases from 50 to 70, even if 0.5, as we said, it may reach to that 100 millimeter of mercury gradient. So obstruction of left ventricle emptying lead to the increased left ventricular pressure and compensatory left ventricular hypertrophy. In turn, this results in a relative ischemia of the left ventricle myocardium and consequent inguinal chest pain, arrhythmia, and left ventricular failure. On examination, the symptoms of the aortic stenosis, there are usually no symptoms until aortic stenosis is moderately severe. In this way, the most common way of the diagnosis of aortic stenosis is by clinical examination. I mean, it is come asymptomatic and find you have aortic stenosis. When the stenosis is moderately severe, when the aortic orifice is reduced to 1/3 of its normal, or at this stage, exercise-induced syncope, angina, and dyspnea develop. When symptoms occur, the prognosis is poor. On the average, death occurs in most of cases within 2 to 3 years if there has been no surgical intervention. And this is that the left ventricular hypertrophy, what we said in the asymptomatic, we'll find this in a clinical examination, or in echo, we'll find hypertrophy and the stenosis of the valve. A large left atrium is indication also. This is that the pressure overload in the left ventricle. The sign of aortic stenosis, a pulse is a small volume and slow rising or plateau in nature. Precordial palpation, the apex beat is not usually displaced because hypertrophy, as opposed to the dilatation. As we mentioned in the mitral dilatation, mitral valve regurgitation, as the apex beat is displaced and does not produce noticeable cardiomegaly if it's isolated. However, the pulsation is sustained and obvious. A double impulse is sometimes felt because of the fourth heart sound of atrial contraction, what's called atrial kick, may be palpable. A systolic thrill may be felt in the aortic area. Sign also during auscultation, the most obvious auscultatory finding in aortic stenosis, ejection systolic murmur, that is usually diamond shape, crescendo, decrescendo. The murmur is usually rough in quality and best heard in the aortic area. It radiates into the carotid arteries and also up to the neck. Presentation of aortic stenosis. With a figure here is the median survival. If the syncope or exertional syncope, median survival about 3 years. Angina is the best really. Increased myocardial oxygen demand, also a mismatch between demand and supply. So it is presented with angina. Median survival without surgery 5 years. Dyspnea is the worst, heart failure on exertion due to the heart failure. Systolic or diastolic or congestive heart failure, median survival is 2 years. And previously we said between 2 to 3 years the median survival, whole age group. It might presented with the sudden cardiac death. And so it is slow rising, and examination of the pulse important. Slow rising carotid pulse, what called pulsus tardus, and decreased pulse amplitude, pulsus parvus. So the pulse is what called pulsus tardus A parvus. Heart sound, soft and split second heart sound. S for Gallo due to the left ventricular hypertrophy. Systolic ejection murmur, as we said, crescendo, decrescendo character. This peak later as the severity of stenosis. Increased loudness doesn't tell you anything about severity. And so the aortic stenosis with the severity mild, moderate, severe, and physical finding. Carotid pulse normal and a mild slow rising is the parvus tardus in a severe, while left ventricular epical impulse in a mild normal. This is the normal and heaving and sustained, while auscultation, as we know, have no relation to the severity. As for gallop in most we see in a severe, while systolic ejection click is even not related to the severity. S2 normal, while single or splitting or paradoxical splitting in a severe. Investigation, chest X-ray reveals relatively small heart, if it is pure, with a prominent dilated ascending aorta. This occurs because of turbulence of the blood flow above the stenosis aortic valve, produce what's so-called post-stenotic dilatation. The aortic valve may be calcified. The cardiothoracic ratio increase in heart failure or the combined valve disease. ECG show left ventricular strain pattern due to the pressure overload, depressed T-wave segment, and T-wave inversion in lead 1 AVL, V5, V6 precordial lead. Echocardiogram readily easily demonstrate the thickened, calcific, and immobile aortic valve cusp. Left ventricular hypertrophy may be seen. Cardiac catheterization is important in aortic stenosis if there is the coronary heart disease or we decided to do a surgery. Echocardiography is the most valuable test for diagnosis, quantification, and follow-up of the patient. So diagnose, severity, and follow-up. Two measurement obtains usually are left ventricular size and function, left ventricular dilatation and ejection fraction, Doppler derived gradient and valve area. So this measurement important. We can give that the diagnosis and prognosis and even decide what the best way of treatment. Mild stenosis, natural history, stenosis to severe, 8 to 8% years it takes until presenting clinical. So it is the most commonly presented in the presented during clinical examination. 20 to 22%, 20% take 22 years, 38% in 25 years. This is a natural history, progression of the disease. The onset of symptom is a poor prognostic indicator. Asymptomatic, good. When it starts symptoms, as we said previously, heart failure, angina, syncope related to exercise, so it is a poor prognosis without surgical intervention. Mostly diagnosed in asymptomatic patient, mostly. This is important to see this curve. In asymptomatic patients, the plateau and go years, even 10, even in say natural history, even to 30 years. But when the symptoms develop, they have the drip or the dip down this curve. Congestive heart failure is the 2 years. Most of patients, they will die. While the onset of the syncope exercise is about 3 years. Angina take 5 years. But with surgery, the curve is become like that. In the valvular replacement, the curve is the without surgical intervention. So grading of severity, mild, moderate, severe, area, as we said, less than 1 cm square centimeter is severe, while more than 1.5, between 1 and 1.5 is the moderate, and velocity, as we said. Cardiac catheterization should be done for a direct measurement if symptom severity and echo severity don't match, or prior to replacement when the replacement is, so that to quantify severity, if the echo can be matched with the severity, do catheterization. If there is a coronary heart disease, do catheterization, or prior to the surgery. Management of aortic stenosis, generally infective endocarditis prophylaxis and dental, high-risk dental procedure with the prosthetic valve or history of infective endocarditis. Medical, it's a limited, as we saw in the pressure overload. Limited role since aortic stenosis is a mechanical, it means pressure problem. Vasodilator are relatively contraindicated in severe aortic stenosis because increase the gradient. Aortic balloon valvotomy shown little benefit. Surgical replacement is definitive treatment of aortic stenosis. Echo surveillance, I mean follow-up in asymptomatic patients. Mild every 5 years, while symptomatic moderate every 2 years, and severe every 6 months. In a patient with aortic stenosis, symptoms are a good index of severity. As we said, without symptoms, go even to the 30 years. With the symptoms, dip down 2 to 3 years, most of them, they will die, median survival. And all symptomatic patients should have aortic valve replacement. Asymptomatic patients should be under regular review for assessment of symptoms and echocardiography. Antibiotic prophylaxis against infective endocarditis if it's indicated. And a simplified indication for surgery in aortic stenosis, any symptomatic patient with severe aortic stenosis includes symptoms with exercise. Any patient with even asymptomatic, any patient with a decreasing ejection fraction, also any patient with undergo cardio bypass surgery for coronaries, do aortic surgery with a moderate or severe aortic stenosis. In summary, disease of aging, most often as a result of degeneration of the bicuspid aortic valve, less commonly rheumatic heart disease, or secondary to degeneration of the tricuspid aortic valve in person more than 65 years old or 65 years old. Look for the sign on physical examination, echocardiogram to assess the severity, asymptomatic medical management and surveillance, symptomatic aortic valve replacement even in elderly and congestive heart failure. This is the chest x-ray. This is post-stenotic of aortic valve. See, it's not in a pure aortic stenosis, no cardiomegaly, and that is ascending aortic valve stenosis. And this is a calcium in the CT scan in aortic valve, heavy calcifications. And the stenotic aortic valve, post-stenotic dilatation, left ventricular hypertrophy and cardiomegaly to some extent. and draw line from this line to that. We'll see above this line, this is the aortic valve, and that the below line is the mitral valve. This calcium in the aortic valve in this chest X-ray. See you soon.